I'm going to go ahead and get it started because, as we know, Rochelle always has so much amazing information that we always go right up to the first of the hour. So I'd like to get us started off on time. Appreciate everyone being here. And it sounds like we kind of sent some accidentally mixed messages this morning, but glad that y'all found us and are here and really excited about this topic, which is a little bit different than we've done in the past, but I know one that's really important because, you know, we spent a lot of time on billing and looking at different things, but Medicare audits and appeals are a crucial part, right? Not everything goes through the first time ever. You know, you want to have a very high rate of, you know, first time submissions being approved because that saves you money, right? If you're constantly working. But secondly, you want to make sure that you're getting and have strong systems in place in case Medicare ever audits, so you can show that you've been following the rules and have very strong policies in place to manage those, to manage your billing. So I'll hand off to Rochelle as I stumble around, and glad to have everyone here today.
All right, thanks, Robert. So today's topic actually came from the survey went out a month or so ago on topics that were of interest to this group. And the audit and appeal process was something that we saw quite a few folks indicate they had an interest in learning more about. So this particular session is going to focus on the Medicare process, which is sort of its own kind of beast, so to speak. We could have a full hour session on commercial payer audits and how those are different. Procedurally, this will focus on the Medicare process, but some of the concepts on how to effectively manage a review or an audit or the appeals are going to apply regardless of who the source of payment is. So when we're talking about Medicare audits and appeals, I'm going to talk about different types of audits because even within Medicare, not all audits are the same. There are a number of different contractors that Centers for Medicare and Medicaid Services contracts with to conduct different types of reviews. Depending on the types of reviews, your rights, the standards, and some of the timeframes even may vary. And so then we'll talk about those types of audits. With some of them are also more severe, more important, more likely to run providers into not more complex issues, not just potential overpayment, but could suggest false claims activity or an indication that Medicare may be pursuing civil monetary penalties on top of overpayments and or criminal charges. So you certainly want to know the difference in the different types of reviews if you were to get one of those. I'm going to spend actually a lot of time on the beginning of an audit. I think the things that happen before the audit or review is even initiated, and the steps that you take as soon as you get a request for medical records are some of the most important steps in the audit and the appeal process. And I'll certainly move on to talk about how the appeals process with Medicare works. But it's a long, expensive process. It takes a lot of time and resources to go through all of the different levels of appeal. So preventing it in the first place is one of the best courses of action. And that's why we have these webinars to talk about the different documentation and compliance and coding and billing requirements as those are changing, especially in telehealth on a rapid basis. But then if you were to get a request for a review or a formal audit, managing it effectively as early as possible is the very best way to set yourself up for success. And we'll look at some things and strategies for doing that. So let's start out first by looking at a few of the kinds of Medicare audit contractors that are out there. One of the most common ones that I see are through the Medicare administrative contractors themselves. So in our area, that's typically WPS Medicare. If you are hospice, home health agencies, I think they use CGS Medicare, durable medical equipment, have different Medicare administrative contractors, but most Part A and Part B services in our areas would go through WPS Medicare. Those that are initiated through the MACs, the Medicare administrative contractors, where you send your claims for payment, they're kind of the contractors that you deal with kind of on a day-to-day basis with your claims. they can even initiate different types of reviews. So one that they do, I'll kind of skip down to the middle one, is called a CERT audit, comprehensive error rate testing program. Now, the CERT audits are not provider specific. They are service specific. So Medicare may identify, let's use telehealth and say Medicare's identifying potential issues with originating site payments. So they may initiate a CERT audit where it's kind of a general survey. They'll pick 40 or 50 random claims across their entire jurisdiction, ask for medical records. And then on WPS's website, when they have findings, they'll publish those findings. So you can go to WPS Medicare right now, go to their CERT page and look at the types of audits and activities and findings that they're posting on different types of reviews. There's a couple of benefits and important considerations with that. One, because it's not provider specific. That means if you get a request for medical records and it says it is a CERT audit, that means your provider, your group, your facility is not a target per se for that review. It is a service that they are generally surveying. And if they find through this kind of survey of 40 or 50 random claims across the jurisdiction, a high error rate, then they may start doing some data analysis of providers that have high volumes of that particular service and start doing provider specific audits and reviews. So certainly if you are part of a CERT audit, it's worth your time to go look on the WPS or the applicable contractor website and see what kind of findings the contractors are publishing, and kind of make sure your providers are addressing all of those potential deficiencies to help you moving forward. Then there's something called target, probe, and educate, which is the target piece is a data analysis, a data-driven focus on particular providers and particular services that appear to be outliers, that appear to have unusual billing patterns. So by the time you have been targeted, in my experience, you can expect that when the contractor does a review, there are going to be findings of overpayments at issue. They're very savvy in how they do their data analysis in a way that's very likely to target claims that have potential errors on them from some of the other CERT and kind of probe general surveys that they've done. So then once they've targeted a provider, they will probe. They'll do something called a probe audit. And a probe audit is generally about 40 claims or about 40 records that are being reviewed. And Medicare will look at your accuracy or your error rate. And again, because this is a targeted and it's not a random review, they're trying to use their resources in a way that is focusing in on claims with a high likelihood of error. You are very likely at the end of that probe audit to have some overpayment findings. So we're going to talk about the implications of that and how you may go through the appeal process. But after that probe audit, you're likely to get some education on any deficiencies. You would have to repay any overpayments that were identified. You'd be entitled to go through the appeal process that we'll talk about this afternoon. But if there is a high error rate, you are likely to get a follow-up probe audit. So again, it's really important to address this as quickly and as early as possible, because if you have a good showing on these probe audits, you may prevent future audits from happening. If after a couple of rounds of probe reviews, Medicare is finding that you're just not addressing the issues or the deficiencies, or your error rate is not improving, then you could progress into what's called an extrapolated or a statistically valid sampling audit. And that's where the reviews can go very quickly from a few hundred, a few $1,000s at issue to hundreds of thousands of dollars, sometimes in the millions of dollars very quickly, because a statistically valid sample involves looking at the universe of claims that you submit for a particular service, selecting a statistically valid sample of those to review, and whatever the error rate is in that sample, Medicare could then extrapolate to the universe. Okay, so the sample itself may involve 2,000 or 3,000, but by the time that is extrapolated to a universe, you could very quickly be talking about hundreds of thousands of dollars or more. So again, it just really emphasizes that getting involved early and really paying attention to these reviews early on in the process is absolutely critical. There's a recovery audit program. Those of you that are facility-based, if you're hospitals, you may have had some experience with recovery audit contractors. They've been in the news a lot in the last decade or so because it was a relatively new program around the 2010 timeframe. And it was fairly controversial because the contractors that were hired to do these reviews were paid a contingency based on the amount of overpayments they find. So they were known for being extremely aggressive reviewers, finding any I that wasn't dotted or T that wasn't crossed reason to deny or reduce payment on claims. They were known for doing that because they would receive their contingency payment. And then a lot of providers weren't, appealing those overpayments at first. Since then, providers have kind of wisened up to the RAC process. They've been very active in appealing those overpayments, and the RAC program is not quite as aggressive as it was a decade ago, and there have been some measures to kind of soften that contingency fee, that aggressive approach that they take. But they are still very active, particularly in those provider types that are facility settings. Now, the MACs and the RACs, we have lots of acronyms today. The MACs and the RACs, they are not necessarily auditors that when they're first reviewing you, that would be an indication of fraud or abuse. They're looking for errors and overpayments. But if they were to see something in their reviews that might suggest fraud or abuse, they can make referrals to other types of contractors. They could make referrals to the Office of Inspector General or the U.S. Attorney's Office to conduct more aggressive reviews. But the zone program integrity contractors, they were ZPICs, now it's called UPICs, but their function is really looking more at something that could potentially be fraud and abuse. So if you were to get a letter requesting medical records and it's from a ZPIC or a UPIC, that's something you really need to pay attention to, because the implications could be huge, not just the dollar amount that's at issue in those claims, but you could be looking at a potential civil monetary penalty, fraud and abuse, which has treble damages and lots of other implications as well. There's several different reviewers that do quality reviews, so QIOs, Medicare Advantage organizations. I find that those are a little bit less common right now. There's qualified independent contractors, which are typically doing a second level. They're doing a review at a second level of appeal that would go to a separate entity than the one that conducted the initial review. So that the idea is that it's supposed to be a new, objective, and fresh set of eyes on your appeal. So let's talk about how these reviews, these audits are initiated. And I want to talk about, even before the audit process starts, there are some things to keep in mind. If in your coding and billing process, if you are relying on any guidance from Medicare, particularly if that's something like a website on the contractor's webpage, I really recommend saving that because websites change. And when the websites change or are updated, they don't necessarily maintain the original or the previous versions of their posts. And I've been involved in a number of appeal processes in the last year or so, where changing guidance on the contractor's website actually became really important to the provider's defense during the audit and appeal process. Other sources like Medicare manuals, coverage policies, It's a little bit easier to go and find previous versions of those, but email correspondence, questions that you've asked to the contractor that they've responded to and you've relied upon, save that because it may be important in defending yourself during an audit or appeal later on. Before audits are initiated, you may receive something called a comparative billing report. If you receive one of these from a Medicare contractor, it's something you really need to pay attention to. A comparative billing report is something that that the contractors are doing some data analysis to identify providers with unusual billing patterns. So if I go back to the previous slide, and we're looking at the target, probe, and educate, that's a really good sign that that provider may be targeted in an upcoming audit. So take a look at what types of services or volume or what the issue is that they're identifying in its comparative billing report, because it is very likely to be followed by a probe review, and you want to be ready for those. You don't always get a comparative billing report before an audit starts, though. It could come beforehand, but that's discretionary. You may not find out that you have some kind of unusual billing pattern or practice until you've actually gotten notice that an audit's being initiated. I apologize, kind of fighting off a cold, and I can tell my voice is getting ready to try to go out on me here. So the next step in kind of initiating the audit process may be a request for you to submit copies of medical records. Now, this is an extremely important part of the audit process. I'm typically, unfortunately, not involved at this stage in the process, and I'm kind of coming in later on once records have been submitted and the contractor has some adverse findings or some overpayment findings, and a provider says, Rochelle, help, we need help appealing this. But this is an absolutely critical stage of the process. When a contractor is asking you to submit medical records, it's really important that you understand what services are the focus of this review. And when you understand what services are the focus, you also need to understand whether there are coverage policies that are at issue, any specific documentation, nuances, like in telehealth, we've talked about consents for telehealth and for remote patient monitoring, or maybe a face-to-face visit before certain services are initiated via telehealth. So you need to understand what the services are and what the rules to support your billing and payment for those services are, so that when you are submitting medical records, you're not necessarily just submitting the record for that date of service, but you are submitting anything that is needed to show you have checked the boxes on all of the documentation and compliance requirements. So one of the pitfalls that I often see in the record submission process is that the Medicare contractor may ask, for example, for the medical records to support your telehealth visit on December 14th, 2021. So you submit the notes for December 14th, 2021. But to support that visit, you may have needed an in-person visit within the previous 6 months or within the previous year, or there may be some prerequisite requirements to that particular service. And if you haven't provided those prerequisite, the documentation to show that you've met all the billing requirements, by just submitting the record of the service itself, you're very likely to get an adverse finding or a finding of an overpayment because you haven't fully justified that you're entitled to the payment for that particular service. In the medical record request letter, look at who it's coming from. If it's coming from a Medicare administrative contractor or recovery audit contractor, this is probably a relatively routine review. However, you've been identified as having some kind of unusual volume or billing pattern in practice that's causing them to initiate this review. If, however, your review is coming from a ZPIC or a UPIC, I highly recommend you reach out to whomever you use as your legal counsel to help you with those, because that often means there may be some false claims components or some significant monetary or legal ramifications to this review that you really want to address head on before you even send the medical records in. The other thing that you want to look at in the medical record request letter is whether it has any indication that the records being requested were identified as part of a statistically valid sample. What I often see is if there are 20, 30, 40 records being requested, providers pull those, they send them in. They may constitute a relatively low dollar value. So, a couple $1,000s. But if they are a statistically valid sample, the outcome of this review could be extrapolated to a universe, and those $2,000 to $3,000 could easily become tens or hundreds of thousands of dollars. So that's something you want to be aware of at the very outset of this process. And then, so we haven't even got to the point of what you submit and when you submit it. We're still just looking at the record request letter. The dates of service that are being requested can only go back a certain amount of time. So unless there is a high likelihood of fraud or patterns of fraud and abuse, typically Medicare is only able to look back 3 to 4 years, depending on the type of audit that's involved, meaning from the date of the request letter, they can only look back to dates of service that were paid, dates of service within the last 3 to 4 years. And sometimes I find that some of the dates of service at issue are just within like a couple of weeks or a couple of months of that date, but may actually have fallen outside the time frame that the contractor can look at. When that happens, you don't want to submit the medical records. You want to call the contractor, identify the issue, and have them either confirm in writing that those particular line items do not have to be submitted, or to send you a new record request letter with those line items removed. If you submit the medical records, knowing that they're outside of the look back period, it could be almost like you're sort of conceding or agreeing to participate in the review process, even though those claims are outside of the review process, and it becomes much harder to kind of claw back any adverse findings at that point. For certain audit programs like the recovery audit programs, you also want to consider that there may be record request limits. So depending on your provider type and your provider size, the contractor may only be able to request a certain number of records from you every 45 days. So in addition to looking at the dates of service and how far back they go, you also want to hold your contractors' feet to the fire, so to speak, and make sure they're not asking for more records than they are entitled to. And then under different audit programs, they may be required to reimburse you for copies of medical records. Typically, for Part B services, you're not going to get paid, unfortunately, even though there is a tremendous volume of medical records, and it's quite frankly can be a significant hardship in some cases to collect those records. But under the Part A program for RAC, you may be able to get compensation for some of your records. And in responding to these requests, telehealth is a really good example. Skilled nursing facilities are another example where the providers and the location of where the records are stored may not be one and the same. For example, the physicians going into a long-term care facility may document their services in the skilled nursing facility's record. So if the physician is audited, they may have to identify what facility the patient was in and go out and request those records from numerous long-term care communities. And that's a challenge because we have a really short time frame to respond to Medicare's request for records, but the physician is responsible for getting the records from all of those different locations and responding to Medicare timely. If you are not able to respond within 30 to 45 days that you're given, you need to reach out to the contractor and let them know that you have some records, but you need an extension. And often they will grant 10 to 15-day extensions while you're waiting on those records from some of the long-term care communities. And that applies in telehealth as well, where we have distant site providers and originating site providers, and the request for records may come to one or the other, but the documentation may be kept by a different entity than the one who actually performed the telehealth service. Okay, so now we're at what to submit in response to a medical record request. So I think it's incredibly important to understand exactly what is being focused on in this audit. It is typically focused on a particular code or a small category, small group of codes that are describing similar services. So that may be, for example, inpatient telehealth services to make sure you're not exceeding the frequency or the frequency of subsequent inpatient telehealth services. It may be a review to make sure you're documenting the originating site telehealth service. It could be a review to make sure you're getting consent provided prior to performing and billing for remote patient monitoring or different care management services. Understanding that and understanding all of the things that you need to submit to fully justify the payment that you bill for and receive payment for are the records that you need to submit. So even if they're only asking for the records for a particular data service, do not limit your submission. Well, this is sort of a strategy, and folks may have different philosophies on this. In my experience, you need to submit everything that is needed to justify the payment, not just what was documented on that particular day. That's my suggestion. And again, any previous guidance you've relied upon, has this particular code already been the subject of a review from Medicare that you have appealed or gotten a favorable finding on? If so, that may be documentation that you want to include as part of your submission as well, not just the copies of the medical records. If you have obtained advanced beneficiary notice forms from patients for the services, you want to submit those as part of the response to the record request as well. Consents for telehealth, any documentation of the level of supervision that was needed and how you met the level of supervision can be very helpful. Signature logs, maybe not so much an issue with electronic documentation and when you have solid electronic signatures, but anytime we have a handwritten note, or maybe it's a handwritten order and the signature is not real legible, it may be a good idea to submit a signature log where we look at that handwritten signature from Rochelle and it looks like a scribble mark, but I have a log of Rochelle Marting. This is my signature. This is my title, my credentials. I'm a physician or I'm a physical therapist, and send that with the records anytime you have kind of handwritten signatures to help avoid any adverse findings that may be related to the legibility of signatures. Now, Medicare has if you haven't seen it, they've got like 15 pages of rules on what constitutes a valid signature. And if you go to Medicare pages that describe the reasons that Medicare denies payment, deficient signatures are almost always on the list. So make sure you're kind of familiar with what the signature requirements are. And it's one really easy way to get ahead of any adverse findings in these audits and appeal processes. Signature attestations, when the slides go out, you can click on this link and it will take you to WPS Medicare's page. And they have a form for a signature attestation. I've had to use this in a number of cases, not related to telehealth, but just to give you an example of how I've used it and it's been successful. For the implementation of spinal neurostimulators, patients have to get a psychological evaluation. And I've had a number of instances where the psychologist isn't a Medicare participating provider, so they don't have to follow these 15 pages of very specific electronic signature requirements that Medicare has. And they may just type out their name at the end of the document, like you're in Microsoft Word. Well, Medicare wouldn't consider that a valid electronic signature. So to avoid any issues with the psychologist's evaluation of the patient to support the payment for the eventual implantation of the spinal neurostimulator, I would send a signature attestation to that psychologist saying, hey, PhD Rochelle Marting, here's your note for your visit with Robert Stiles on such and such date. And this says, I, Rochelle, saw Robert Stiles on data service ABC. This is my signature, and they sign it. You send that in with your records, and it helps avoid any denials due to deficient signatures. And that's been a pretty successful strategy whenever I look at the signature and think, gosh, that may not pass muster based on Medicare's signature expectations. I also recommend that you document every patient, every data service, every code that is subject to review that's being requested. It is very common in my experience when you've got a lot of claims that are being reviewed that Medicare's decisions may not capture all of the claims that they asked for, or that as you go through the appeal process, they may forget to give you a decision on one claim. So I think it's just really important to keep track of this as you're going through the process, kind of your own reconciliation. And then finally, I think this is maybe the most important step in the process. I have found it to be incredibly successful when you're submitting the medical records to actually treat that like a mini appeal, rather than just sending medical records to the contractor. Explain, here's the code that we build. Here are the requirements for payment. Maybe that's a checklist that you put together. And you can, for each patient, for each code, you walk through how you met those requirements. And I even will go to the medical records and document, here's requirement number 1, and I circle it, and I'll put number 1, consent for telehealth. And I check that off. Requirement number 2, direct supervision. Dr. Smith was in the office, and I marked that off. And when I send that in, it makes it so quick and easy for the reviewer to visually see, here's all the requirements, and to look at your note and see number 1 through 10, exactly where it was recorded. And I found that to be a very successful strategy to have good results at that medical review stage to avoid adverse findings and the whole appeal process entirely. So now let's talk about actually submitting the records. For most of the types of reviews, you'll have 45 days to submit your records. However, pay attention to the record request letter. Many of them I have found tell you that you have 30 days, even though the rules for the various contractors actually say you have 45 days. So certainly do your best to respond within the time frame in the letter. But if you find you're having difficulty getting all of those records because of the volume of information that's being requested, or maybe you're having to rely on a number of different providers, originating sites, distance site providers, facilities, to get those records to you, I would reach out to the contact on the request letter and say, hey, I know this says 30 days. Our understanding is under the manual provisions, these are all in the program integrity manual on Medicare's website, that we actually have 45 days, and we just want to confirm we have until the 45-day mark, or can we get an extension? Have them email you, have them send you confirmation in writing anytime you get a request for extension. Even if they give you that verbally, you want to have that documentation that an extension has been granted, because oftentimes the person doing the review is not the person who's kind of in charge of the audit, who's kind of signing off on the letters. So the reviewer may not be aware that you have gotten that extension. Send the documentation of that extension in with any records that you have to send in after the 30 or 45 days that were granted in the initial request. The next thing I highly recommend doing is bait stamping everything that you send in. So you're keeping not only internally a track of all of the patients, all of the dates of service, and the codes that you're submitting for review, so that you can account for those when you get a decision back, but also the documents that you're sending in. So I typically, I wouldn't send this in patient by patient, just fax it to Medicare as you get them. I would have this packaged up as a complete response to Medicare. I kind of treat this like a mini appeal. I review the records at this stage with the same level of scrutiny that I would review them if I were preparing an appeal. So I'm doing that all up front, and kind of writing out this sort of cover letter for the reviewer to make it, you want it to be as easy as possible for them to approve payment and avoid the appeal process. So in doing that, can I have my whole nice packet of information that I can then scan in, and you can use Adobe. There are lots of free PDF programs that will bait stamp every page of the document for you automatically. You don't have to go in and manually put a number on every page. I think that's so important, because when you get the decision back, it happens. Unfortunately, I would say it has happened in more audits than not, that I get a decision saying we didn't receive records for Rochelle's December 14th date of service, when we did send them, and it was bait stamp page number 100. And you can respond with that information, hopefully without having to go through the appeals process. When you send the records in, make sure you're following the instructions on the record request letter, but call to confirm with the person on the medical record request letter that they've received them, just to make sure there haven't been any issues with fax transmission. Snail mail during COVID has been really slow, so you want to make sure that they get it within a reasonable amount of time, or you at least let them know that it's in the mail. If you're faxing, keep a copy of your fax confirmation receipt. Make sure the page numbers, the number of pages faxed, match the number of pages you submitted. If you're snail mailing, send it with a method that you can confirm tracking or delivery, and keep a copy of that. Then once you have submitted, you want to put a reminder in your calendar to track how many days until you should expect a decision. So if it's been more than 30 to 60 days, depending on the type of audit, then you may want to reach out to the person on that medical record request letter and say, touch base on the status of your review. So now at that point, you'll get a decision letter. And they're kind of, with Medicare reviews, there are two parts to this. You'll get a decision letter, and that's when you can take a look at the decision, reconcile against your list of claims, make sure they've addressed anything. Are there any clear errors, like we didn't receive records for a particular date of service, and you submitted those, that you can address. But your time frame to appeal doesn't start until a second letter called a demand letter is received. The decision letter is only going to tell you whether the services you billed were supported. It's not going to quantify those. The demand letter quantifies it and tells you how much Medicare is asking to be repaid. When you receive the demand letter, that's when your time frame to submit a first level of appeal begins. And I will mention too that this is if you have an audit, a formal audit, you can appeal claims on a claim by claim basis as well. So if you get a denial on a particular claim, you can also submit an appeal from the date that you get the remittance advice, within 120 days of getting the remittance advice, or if it's a formal audit, you would appeal within 120 days of the demand letter, not necessarily to the decision letter. I've also had cases, I've also had cases where we got a decision letter and the demand letter never came. And we waited and we waited. And that's something that you may want to consider internally or with legal counsel, what you do if a demand letter is never issued, because your repayment obligation, your appeal obligations may not be triggered unless and until you get a demand letter. So that's something to think about too. Let's see, talk about that. One one significant challenge, particularly if you have a lot of accounts that are being reviewed, is that when you have any adverse findings or overpayment requests from Medicare, and Medicare was the primary payer, Medicare may automatically notify any secondary payers on the claim that there was an overpayment finding, and you may start to receive refund request letters from secondary payers as well. And this begins a really challenging process, particularly if you are going to appeal Medicare as a primary payer's findings. And as you appeal, you may have accounts overpayment findings overturned at different stages in the appeal. You then have to reach out and appeal those refund requests to all of the secondary payers. So you can see how this gets really hairy really fast. The recovery audit program also has something called a discussion period, which is sort of like a pre-appeal process where you can reach out and discuss the claim before filing a formal first level of appeal. Under the regular review process, there's something called a rebuttal that you could file that would stop Medicare from demanding a refund or recouping any overpayment findings from recouping or offsetting from future claims. The timeline for this is really tricky. You have to submit it within 15 calendar days of the date of the demand letter. The demand letters come by snail mail usually, and unfortunately, I have found that the providers often don't even receive the demand letter within 15 days of the date of the letter. So by the time you receive it, you may actually be out of time to submit a rebuttal request. A rebuttal request is explaining to Medicare why you should not have these amounts recouped or offset. It is a really high standard to meet. It can't simply be a disagreement with the findings. It has to be something like a financial hardship. It may be more common during the COVID public health emergency, but it could be something like, I don't know, the provider's hospitalized due to COVID and can't prepare a response, or tornadoes in Kentucky, the provider's office has been flattened or something along those lines. So that's a really high standard to meet. Then we get into the appeal process, which is for Medicare, 5 different levels of appeal. I'm really going to focus on the first 3 because that's really where most providers would either have success or decide to no longer pursue future levels of appeal. So I'm going to start with the first level of appeal. This is when you get the demand letter after an audit that identifies a potential overpayment or asking for a refund. You then have 120 days to appeal. So anytime you get a demand letter, I'd suggest putting on your calendar that deadline, and Medicare has to receive your appeal within 120 days. So especially if you're sending this by snail mail, you probably want to plan on sending that at least 10, 15 days ahead of time, because it takes quite a while to get there, get to the mail room, and get processed and marked as received. If you have someone helping you in the appeal process, so you have a consultant or legal counsel, or they may need to prepare and submit an appointment of representation to go along with your appeals. Now, on the WPS Medicare website, they have forms that I highly recommend, even if you're going to write out an appeal letter, that you use this form from WPS's website, because there are certain things you have to address and identify when you submit an appeal. And that cover letter is designed to capture all of those elements. So things like the patient's name, the claim number, the Medicare ID number, the date of service. And that form will help you make sure you capture all of those elements so you don't get sort of a technical rejection to your appeal. I can tell I'm going to sneeze here. Excuse me. Sneeze or yawn or something.
Well, and just to jump in here, I wanted to see if, I know we've gone through a lot of information, if anyone has questions. I don't see any in the chat other than whether or not we will send out the recording and presentation, and we absolutely will do that afterwards via email. But if you have other questions about anything we've covered today, now might be a good time. And then we'll just see if some of those come in the chat. And I also wanted to mention, if you received a secure message from me today, I accidentally sent the HTRC email securely this morning. So you can disregard that. It was just a webinar update. It's if you click on it, it's not a virus or anything like that. It would just give you the webinar information. So I apologize about that, but it's something you can just disregard or delete.
All right, got my sneeze out there. So when we get to the first level of appeal, it's called a redetermination with the Medicare program. This would typically go back to the Medicare administrative contractors. So one challenge I have with the first level of appeal is that often it is the same entity that's reviewing your appeal, which made the initial decision. So I have found from my experience, it's difficult to get decisions overturned at the first level of appeal. And if you haven't already had a favorable review finding at that first level. So keep that in mind. They typically should be issuing you decisions within 60 days. So whenever you send your records in, mark your calendar for 60 days. It may take about 75 or more because, again, there's going to be transmission time getting there before they mark it as received. And then there's going to be some transmission time coming back. You can potentially submit additional evidence in this time frame before a formal decision is reached as well. So for example, if you've got a really nice reviewer, they may reach out to you and say, hey, Rochelle, we noticed a particular note didn't have a signature on it, or we can't read the signature, or the documentation kind of came through sort of fuzzy and we can't read it. Could you resubmit? So if you are submitting additional documentation while Medicare is doing the review, that every submission extends their deadline by 14 days. Although one of the challenges is that it could take them 120 days. It could take them 180 days to get a decision. And sometimes it does if it's a really big audit and you're just kind of stuck waiting. You don't have a lot of recourse at this level of review. Depending on what the issues are, you can expect that, or you should expect that if it is a coding issue, that they generally will have certified coders making your decisions. And if it's a medical necessity or clinical issue, they generally would have clinicians making that decision. But that doesn't mean that they're going to have physicians in the same specialty as your provider making those decisions. It could be a registered nurse making decisions that a neurosurgeon, for example, has performed and documented. So that can be a little bit of a challenge sometimes. To give you an idea of the types of cases and services that are appealed, this kind of shows you from a few years ago. Medicare breaks out the different categories of services that were submitted for redetermination, kind of the percentages. So let's see, outpatient, hospital outpatient, their physician services, professional services are, and this is my experience too, one of the biggest categories of appeals that are submitted to the Medicare administrative contractors for review. Now, this shows you the likelihood of success at level 1. So the red is unfavorable, so about 50%. Fully favorable, though, this has kind of increased over time. When I started doing these about 10, 12 years ago, fully favorable was like 15% at that time, to avoid a backlog of appeals at higher levels of review. We're starting to see a greater likelihood of success at level 1 appeals. And ideally, you don't even get to level 1 appeals because we're kind of learning strategies to handle these at that record request level without even having to go to the appeals process as well. And if I get involved kind of at the redetermination process, I handle it the same way, trying to make it as simple and easy for the reviewer to approve our payment as possible. So then if you're not satisfied, if you have a partially favorable or unfavorable decision at level 1, you could go to a second level of appeal. There are forms from the Qualified Independent Contractors, which is a different review entity than the entities that do the level 1 appeal. So the idea, I don't know if I agree that this is how it actually turns out, but the idea is you have a fresh set of eyes from an independent legal entity, an entirely separate contractor that's reviewing your claim, so that there's maybe less incentive to continue to deny payment for those. You have 180 days from the date that you get your first level decision. So you have 6 months to submit your level 2 appeal. If you want to stop recoupment and offset activities, though, you only have 60 days, which depending on the volume can be a pretty quick turnaround time to be aware of. One thing that is really important at this particular level is that you have to submit all evidence that you would want to use at any further level of appeal at level 2. So if you were to go to a hearing, which is a level 3 appeal, if you were to go to the Medicare Appeals Council or eventually to court, unless there's good cause, they're going to hold you to everything that you have submitted at the second level of appeal. That has in some cases been challenging for me in the past because I didn't get involved until later on in the appeal process, and I'm kind of stuck with what's been submitted at that point. Let's see, after you submit the records for reconsideration, you should have your decision within about 60 days. And again, that's also kind of bumped out 14 days every time you're submitting additional information. Here, though, if the contractor is not issuing their decision on time within 60 days, you could escalate your appeal and go ahead and file a request for an administrative law judge hearing. And that ability was put in place many years ago as a way to sort of expedite the review process. That right doesn't really afford most providers any expedited reviews currently, because there is a tremendous backlog at the administrative law judge level, which is the third level of appeal, to the extent that there are a number of cases that I've been involved with recently where the administrative law judge hearing is just now being held for appeals that were filed like 5, 6, 7 years ago. So sometimes it's better to just sit back and wait another 30 or 60 days to get your level 2 decision. But there can be some strategic decisions in whether or not you wait for a level 2 appeal or proceed to a level 3 administrative law judge. If you have been submitting your appeals quickly, so instead of waiting for the full 80 days, if you file within 60 days so that Medicare doesn't recoup or offset this overpayment balance against current or future claims, once you submit your level 2 appeal, that stay of recoupment ends, and Medicare then can start recouping or offsetting this alleged overpayment balance from current or future claims, even though you haven't reached necessarily exhausted all of your appeal rights. At this level, if there's any question of medical necessity, the independent contractor has to use a panel of physicians or other appropriate healthcare professionals, which often are registered nurses making clinical decisions at that level. They are not bound by any decisions at the lower level of review, but they do tend to give deference to those levels of review. Sometimes there is a clear error at this stage, and I've had good success going back to the contractor saying, hey, you said you didn't receive the records. Here are the records. Here's evidence that we submitted them, and they would reopen their decision and issue a revised decision rather than taking that clear error to a next level of appeal. So this slide shows actually as time has progressed that the second level of appeals are less likely to give you a favorable decision than the first level. So just kind of a comparison. Here was the level 1. So you see the red is the unfavorable, where we actually have more unfavorable decisions by the time we get to a level 2 appeal. That could be because everything that's real cut and dry and should be overturned has already been overturned. But I find that the second level of reviewers have been fairly aggressive in recent years. And if you go to a third level of appeal administrative law judge hearing, they've been more likely to participate in the hearings and try to support their denial of services. So at this level, we would be going to administrative law judge, and you have to have a certain amount at issue to even qualify to request an administrative law judge hearing. But if you have multiple claims at issue, it's only $180. So it's pretty easy to meet that minimum amount in controversy. Your time frame to request an ALJ hearing is pretty fast once you get your level 2 appeal, and you've got to get that turned around within 60 days. There are forms available to do this, and I'd really encourage you to use those forms because there are very specific things you have to do at the administrative law judge level. You want to make sure you get all of that documentation in place. And you're submitting it so that you don't get your request for hearing dismissed for kind of technical reasons. Let's see. You have to send a copy of the administrative law judge hearing to all of the parties that were identified on the level 2 decision letter. So that may be the QUIC itself. It could have to go back to the Medicare administrative contractor, but these are all kind of procedural and technicality things that you just don't want to miss these little steps, because the ALJ could dismiss your request for appeal if you're not kind of dotting all of these I's and crossing all of these T's. At the administrative law judge considers these de novo, which means it's a fresh review. They do tend to give some deference to the previous level contractors, but they don't have to. By statute, the ALJ is supposed to give you a hearing and have your decision within 90 days of your request. That's not going to happen. At least right now. As I mentioned, right now, the backlog is years. So at the time that you submit a request for an administrative law judge hearing, at this point, it could be 2024 or 2025 before you actually get a hearing on your claim. But there are different types of hearings. In-person hearings are very rare, especially right now during COVID. Most of these are done by phone. I've had a few that were video teleconference, so essentially on Zoom, or you can request an on-the-record review. And instead of using time and resources for a phone or video conference hearing, you can ask that the ALJ just review the record, meaning the documents that have been submitted, and make a decision based on that. This is a process where you could have some pre-hearing discussions with the judge to address evidentiary issues. So it's kind of like a mini lawsuit. It's much less formal than a lawsuit, but there still are evidentiary standards and processes that have to be followed. And if it's a large dollar amount at issue, you want to be very careful with following those processes, because if this were to proceed to level 5 appeals where you go to court, You want your record to be nice and clean and have all of those I's dotted and T's crossed. You can have witnesses during an administrative law judge hearing. So for telehealth services, that may be the supervising provider on the hearing to say, yes, I was in the office suite and immediately available. It could be the provider of services. It could be a coding expert or other witnesses. And if Medicare participates in the hearing as a party, they may have witnesses to call as well. And it starts to feel a little bit more like a trial when you have CMS participate in the call, because they can cross-examine your witnesses, you can ask questions and cross-examine theirs. This is just, you can go to the link on this website. There are a bunch of forms that you can use so that you don't have to reinvent the wheel if you're filing an ALJ request. And then this kind of shows you the breakdown on a lot of claims getting dismissed at the ALJ level. That's because those technical requirements aren't being followed. So half of the claims may be dismissed because requirements aren't being followed, or maybe because they've been resolved through some special initiatives that are currently available if you file an ALJ request to get your issues resolved without actually going to a hearing. So there's something called the settlement conference facilitation, statistical sampling review, and these are essentially expedited ways to have disputes resolved because of the tremendous backlog of appeals at this third level of review. And I know I'm at my time and I want to be respectful of everybody's time. There are 2 other levels of appeal after that, but most providers, by the time they get to a third level of appeal, if they haven't been satisfied, would probably resolve their claims at that point and decide to either overpay or try to enter into settlement discussions with Medicare. But there are 2 other levels where you could eventually end up in federal court that could be options. And those could be particularly important if you have a lot of procedural issues, statistical sampling where you have very high dollar amounts that issue or a claim that you think is a service you're providing a lot in your practice that could be important, not only for you, but for other providers in your specialty area across the country. So I'll stop there at 1 minute over. As Robert said, I'm always going up right on my time and can never seem to get you out early, but certainly welcome any questions that you have, and we'll stick around for those questions. And if I'm not able to answer your questions now, I will answer them in a follow-up after the session.
As always, remember, we're always available by email or on our website for your questions or to provide technical assistance. Are there any questions before we head out? I know some may need to let go, but I want to leave some time in case there's something that just needs to be clarified. If not, please reach out. We're always happy. We know these are very complex topics, so we will see you for our next sessions. And Christy, really quickly, if you want to let us know about January.
Yeah, we have our January dates. The next one will be January 12th at noon, and we'll do an update on Medicaid agencies' telehealth policies. And we'll be sending you dates, Zoom links, all of that through email. Thank you.
Thanks, everyone. We really appreciate your participation throughout the last year and looking forward to keeping going next year. Thanks so much.